keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, I'm Leslee Shaw, Professor of Medicine at Emory University and Associate Editor at JACC Imaging. We're here in New Orleans for the ACC's annual meeting, and I'm joined today by two esteemed colleagues. To my right is Dr. Christopher Kramer from the University of Virginia, also an Associate Editor at JACC Imaging, and Dr. Raymond Kwong from Brigham and Women's Hospital in Boston. Good afternoon. Hello to both of you. And we're here to talk about gender equity in cardiovascular imaging, and you have some interesting results to share with us today, Dr. Kwong. Maybe you could tell us a little bit about your study.
So this was a study conducted at the Brigham and Women's Hospital a number of years ago, and we had started a stress cardiac MRI program a number of years ago, and since then we collected information about prognostic information of patients who were referred to us for assessment of ischemia, and we assessed specifically, wanted to know whether cardiac MRI can be an effective tool in looking at the prognosis of female patients, and specifically wanted to know if there's a difference between the gender being a modifying factor. At the end of the study, after a number of years of follow-up, we focus on sort of heart events or non-transportable events such as cardiac death and myocardial infarction. We found that the findings from MRI were fairly effective in determining the patient's or predicting the patient's long-term outcome in developing these events. But more importantly, most interestingly, was that cardiac MRI was an effective tool when it's negative, that patients were very unlikely to have a significant event such as cardiac death or myocardial infarction.
Interesting.
And Ray, you were using adenosine vasodilator perfusion MR imaging. How do you see this as relating to the alternative modality of stressing with cardiac MR, dobutamine stress MR?
Yeah, as you pointed out, there are other groups, and there are papers in the literature that show that dobutamine cardiac MRI is a very, very viable stress cardiac MRI modality. And there's also similar data that show that dobutamine cardiac MRI can effectively risk stratify female patients. I think this study is complementary to the Hunley's group data that show dobutamine's prognostic significance. I think stress cardiac MRI using vasodilatation such as adenosine is somewhat easier to use on a technical level, and it's potentially maybe on the stress medication level is associated with fewer side effects. But I think both modalities are very useful. They're very safe overall, and I think this shows that there are more than one choices when it comes to stress imaging, and often we can choose depending on what fits the patient's profile best.
This is really exciting. It's exciting news. It's exciting news for because of a lot of historic perceptions that all of our imaging modalities don't work very well in women. But now we've had data on stress echo, now we've had data on stress nuclear, and now in a growing abundance of data that all of our conventional modalities work very well in risk stratifying women. I think that has far-reaching implications for our audience listening here for us today. And maybe you could comment on some of the strengths of cardiovascular MR, independent of wall motion, independent of perfusion, that also I think make it very advantageous for our listeners.
Yeah. That's a very important point, Leslie. Some of the advantages of cardiac MRI, historically, maybe I should take a step back. Imaging women's heart is challenging because of a smaller size heart, and so it's a little bit more demanding on spatial resolution limitation. Women also tend to have higher tendency to have tissue attenuation, so make techniques such as nuclear techniques somewhat more challenging. Using regular exercise treadmill tests has been well known to be associated with higher chance of false positivity in women. So those choices, those issues make imaging of women somewhat more challenging. The benefit of MR on a technical level is the fact that it does not use radiation, so compared to nuclear imaging is a potential advantage. It does not, it has higher spatial resolution. It can image infarction and perfusion separately. So with the higher spatial resolution, one can conceivably think that MRI can detect a higher degree or a smaller degree of myocardial ischemia. And the fact that it does not have use of ionizing radiation is specifically potentially advantageous to women. So those are the technical potential advantage of cardiac MRI compared to existing modalities.
That's excellent. And do you think those small amounts of ischemia that you're perhaps able to detect may be the reason why you have such a low negative event rate of 0.3%, which is amazingly low compared to the other modalities?
I think the high sensitivity that we notice in detecting coronary disease in this data set is certainly suggestive of as you said, the high negative event rate, being able to rule out disease, and in this case, have a reassuring profile for the patient is certainly suggestive. The data certainly suggests this is the trend.
That's a great take-home message, and I think one that we're very excited in the field of cardiovascular imaging now to have a number of imaging modalities which are highly accurate for not only our male patients but as well from our female patients. So I want to thank you both for joining us here today. This is really a clear advancement and improvements for the effectiveness of cardiovascular imaging for our female patients. So thank you.
Congratulations.
Thank you.